Welcome to the Illuminating Primary Care Podcast.
Hello and welcome to another episode of Illuminating Primary Care Podcast. My name is Rohan Fletcher, Specialist Consultant in Nursing and Allied Health at Menlo Park Recruitment, and your host for today's podcast. I'm joined today by Yuen Toh. She's a partner at Boultham Park Medical Practice in Lincoln. Yuen is a courageous and compassionate leader influencing change. She's the first Clinical Pharmacist Joint Clinical Director in Lincolnshire. She created support networks for pharmacists and technicians across Lincolnshire and is an expert speaker for CPPE. And on advisory panels for the Lincoln University Pharmacy Programme. Yuen is currently the clinical lead for primary care education and networking sessions, and leads monthly education sessions for clinical pharmacists across the ICB. Welcome to the podcast, Yuen.
Hello. A few new hats on there. So that was an older CV. So since then, I am now also a pharmacist partner, hence the title, in Lincoln. So first non-GP partner, I should say first pharmacist partner, because we've got other practice managers as partners in Lincolnshire. So that is relatively new. So I am in post now for 6 months as a partner. And also I'm the co-host of the Imperfect Clinician podcast, where we talk about burnout and general well-being for clinicians in general.
Fantastic. Thank you for that, Yuen. So, a topic that we've chosen to look at today is that of rethinking partnership in general practice. And I suppose how perspectives have changed from the original GP-only partnership model to now seeing the introduction of other clinicians taking up partnership positions such as yourself. We'll also look at practices, PCNs and the wider system, as well as making sure patient engagement is as efficient as possible. So yeah, over to you, Yuen, to get started.
Yeah, so I think it's important to examine the different perspectives within general practice partnership. So when you look at, like yourself has mentioned, around that, it's usually quite GP led. However, when you're thinking about different clinical backgrounds, whether that is pharmacists, nurses, paramedics, practice managers, for example, the various, I'm coming from a clinical perspective, so I'll talk more about the varying clinical backgrounds of clinicians within partnership. That diverse experience and expertise contributes to better patient care, because you bring a wealth of knowledge and skills within your own specialty. So, for example, the GP understands the diagnostic pathway, pharmacist understands sort of prescribing pathway, medication safety, prescribing habits. So that when you look at having a different clinician on the level of partnership, it's worth to consider what value you can take in. So from the perspective of, if you are a pharmacist and you want to become a partner, think about what are the strengths that you can bring in the partnership that nobody else within the current partnership has got. So identify your own strengths and making sure that you do talk about it. Because a lot of the time, sometimes I've noticed that pharmacists are quite good at doing what they're doing, but not really promoting it or singing about it or shouting on the top of their voice about it. So I think that's one thing, because when you have an MDT within the whole of the practice, whether that's clinical meeting or discussing about case studies, bring your thoughts, bring your contribution to those meetings. Don't be afraid to speak up and be confident about what you're going to say, because your opinion really do matters. And remember that you're providing perspective that people can't, because they're not trained as pharmacists. They're not gone through the same journey as you, understanding patient journey, because patient journey is so multifaceted. So your role as pharmacist will give you that. I think from the perspective of a partner now, when I look at, for example, partnership, what do we need and what do we lack? We'll talk about in those other 2 points that you mentioned. But considering that if you only have one group of people in the partnership, what you do is you might potentially have more blind spots that you yourself don't notice just because you're not
Yeah.
aware of it, not because you're intentionally doing so. So
Yeah.
when you create more diversity on the table, you're thinking about all types of diversities, not just career or the professional, but you're thinking about diversity in terms of gender, in terms of race, in terms of sexual orientation, a few other things, because the more diverse the people on the decision making board is, the more blind spots you're going to avoid, because you're seeing those people's experience are covering places that you perhaps understand a little bit, but not as much because you've not lived it yourself. So I think
I
that,
suppose the wider patient base is better represented, isn't
yes,
it, with a wider range of, as you say,
exactly.
different genders, different sexual orientations, different, clinical backgrounds, I suppose.
Yes, and that directly translates to patient outcome and patient care, because if you are serving a very diverse population, whether it's age or any of the things that we talked about, when you have that group of people or partners thinking that way, and or maybe even able to communicate to those groups better, you will have more engagement. So if you want to do any co-production with the patients or with the population, you will get better engagement, and hence you get better outcomes.
Brilliant. So were you the first non-GP partner with your practice then, Yuen?
Yeah, so in Lincolnshire, from what I know, the only non-GP partner previously when I first started was a practice manager. Now I am hopefully seeing more and more pharmacists becoming partners. I think sometimes people notice that pharmacists become partners because it's a dispensing practice.
Right, okay.
And I want to break that myth. It's not that is your only route. Yes, that might make your route a little bit easier, but in my practice, we're not a dispensing practice. So I know, if you have a dispensing practice, it makes sense to have a pharmacist partner because you know the ins and out of running a pharmacy, but it doesn't have to be that way. That's not the only thing.
Yeah. Okay, brilliant. And just following on from what you've mentioned there, since you've kind of joined as partner, have you found, in terms of just going back to that kind of representation for patients, have you found any kind of feedback from patients in terms of, or has it been something, I suppose, that's been clearly noted by patients that there's been a difference since you've joined as partner, or is it a bit too early to say still?
No, I joined our PPG, so patient participation group. So I was there to explain my role and what I do. And they were asking a lot of questions because it's their first time as well, seeing pharmacists being a partner. So they're asking a lot of questions, both from PPG perspective, but also from the clinical perspective. So that has helped in terms of the understanding, and my relationship with the PPG has been really good. So that, I think, being visible is really important. So not just being visible to your clinical colleagues, but to your patients and to other practice staff. So reception team or anybody that you come across, really, secretaries, admin.
Yeah, no, definitely. And I think it's a good point to make, because some of the conversations I personally have with, clinicians when they're looking at, joining new practices is that kind of, I suppose, visibility and approachability of partners as well. And I think those practices that do have not just GPs as partners, but do have, other clinicians such as yourself as a pharmacist, or, whether it might be a kind of AMP partner as well. I think they often show a bit more kind of a forward-thinking attitude, I suppose, in terms of, as you've mentioned already, kind of representing different clinical backgrounds, which is often more, I suppose, well received, I would say, than those that are just solely kind of the older model, I would say, of just solely being GP led. So I think it does, help to make a difference when clinicians are looking at joining practices as well.
Yeah, I think it's good that we talk about what's great about it, but we also need to address there are potential challenges for people who are considering a non-GP partnership so that they can be
Yeah,
prepared, because clinicians, when you come from different background, you'll communicate differently. So, for example,
yeah,
some people might prefer very data-driven discussions, whereas some emphasize on patient narratives. There's no right or wrong. Perhaps if these two marry together, that will be a great approach. But
yeah,
bridging these communication gaps is essential, because if you essentially you're looking at not just communicating but collaborating with each other.
yeah,
And the learning curve, I think that is something that needs addressing, because a lot of people think, oh, being a partner might not be very much different from what I'm doing now. But the learning curve is really steep, because you are all of a sudden from a clinical role and perhaps more involved with the processes and the protocols to a business. So running a business,
yeah,
understanding everything that's associated with it, staff, um, finance, and everything else that's associated. So I think it's important that people find out more. So by listening to this, share it to your friends who are interested in being partners, but also your local LMC will have partnership sort of webinars. So utilize
yeah,
those and ask questions. Ask people who are doing it already, or people who've been doing it short time, longer time. LinkedIn is where we met. So it's a
yeah,
good space for people to utilize these platforms that are already available,
yeah,
and very visible partners, pharmacist partners, or any other role that you are in, and say what first of all, what is it actually like, and second of all, what do I need to get there? And for GPs who are in a partnership thinking, oh, I want to know a little bit more, reach out, because
yeah.
there's no point learning in silo, because if we reach out, then we'll all have collective growth.
Definitely. Yeah, collaborating with each other, I think, is the best way forward. Perfect. So, and yeah, just kind of moving on to the kind of second point we'd plan to discuss then. So, in terms of kind of, I suppose, exploring kind of practices, PCNs, and the kind of wider systems. And I know you mentioned when we spoke before about ensuring there's somebody kind of external as well, being very important to rethinking partnership.
Yeah. So just to give a bit of context to our discussion between Rohan and myself, is the practice, in terms of how the practice used to work, we need to rethink that. And I'm sure there are a lot of other innovative future or forward thinking practices and PCNs, but working alone is not going to work anymore. So hence the PCN is there for practice to work with each other. So we'll start with that first and then we'll go to the wider system. I think practices working with other practices, with neighbouring practices in a way, to form PCN, the collaboration that you have helps, because any issues that you have, you're not just having it in your practice. You might ask the neighbouring practice, say, what's actually happening. Perhaps all of that conversation has happened on and off, but not as
Yeah,
officially or not as structurally in this way. So I think it's important. I think my role as a clinical director helps to bring that strength into the partnership, because my role as CD is I speak to practice regularly and see, what is being done well and how can other practices learn from that, or maybe one practice has learned from a setback, how can other practices learn from that? So opening that learning and development together, so we can, if one practice is better, we can all be better. So
yeah.
it's not learning in silo anymore. And
Sharing best practice, isn't it?
exactly. And I think in my case, I started off being a lead PCN pharmacist. So I created a team from scratch that span across all practices. So really, I was the only one who had insight into each practice, because I had teams in each of the practices. So anything get fed back a lot quicker. Whereas if you're not actually doing it, because initially when it was just me, I was covering all the practices all throughout the week. And it
Yeah.
helps actually now in hindsight, even though it doesn't feel like you get a lot done because you're only there once a week.
Yeah.
But by doing that, I know most people in the practice and most people that are still there. So when I come back in a way, or when I start discussion with them about my role as CD, they know me. So I don't have to start from scratch.
Yeah.
So when I talk about building relationships and invest in that, that will give you returns in the longer run. You might not see it straight away, but making sure that you liaise with practice and PCN team, and it might be some path of people that you don't really cross. So, for example, frailty team, the FCP team, the first contact practitioners, dietitian, if you've got some physician associate, any of these groups of people, it's important that you understand how they work, how you can work better together, because any of the conversation that you've had, I describe it as like a piggy bank, like an investment into it. And when it gets to a certain point, everything will get fed back to the groups of people, or essentially the decision making groups of people, and people will know. So that's how you build your reputation. I think that's one of the part that's important. So going back to what we talked about in regards to collaboration. So I posted something on LinkedIn previously about collaborating on care pathways. So, and I'll share a bit of story so people can understand where I came from. So we, our adult eating disorder pathway was done a little bit differently at the start, where the minor group gets sent to, or minor to moderate group gets sent to counselling. However, counselling people are not as trained in eating disorder. So by looking at the data, I was speaking to the consultant psychiatrist who's the clinical lead for adult eating disorder, and we say, you know, how can we make it better? And how can we assess capacity? So secondary care has got the capacity, and the data showing that if you intervene earlier, you got almost double the recovery rate. So it doesn't make sense to spend all of our resources and the time to the more severe group, or only just the more severe group. We should be able to widen the net to everybody. So we came up where the pathway was amended to all adult eating disorder going to the secondary care group. So that includes the consultant psychiatrists, ANPs, health and wellbeing coaches, a group of people who are specifically trained in adult eating disorder. So that's a start. So by doing that, we're trying to think about, first of all, how will it impact general practice colleagues? And in this case, I'm trying to reduce the change that we always have, because another referral form, meaning, we have to change that again. So I'm trying to make things a little bit easier so I don't come up with that much resistance. And so it resulted in no change in terms of the referral form. It goes to a single point of access. So like a triage model for secondary care, and they decide where it goes. But also I wanted to make sure that there is conversation around self-referral, because when we talk about eating disorder, we have to consider the age and the population that we have. So we don't want to make it only a clinician referral. We want to make sure it's a self-referral. So then there is conversation with university, for example, and we can, in a way, increase awareness using our social media, posters in the practice website, so patients can refer directly, and perhaps even staff. You might not know that anyone that you're working with, either they are struggling with it or their family member is struggling with it, but don't know anything about this. So when you do something like this, I want to see it as a ripple effect where it will affect other people as well. And so hopefully the uptake will improve, and then we'll gather some both qualitative and quantitative feedback from patients.
Yeah, no, absolutely. No, it sounds as though those, putting those kind of plans in place, making everything run as smoothly as you possibly can. You know, I know you said you did it a bit differently, but it's something that, you know, if it works, you know, through that collaboration with everybody else, and, you know, it's something that works for the patients. And, you know, as you say, sometimes there are scenarios where someone you're working with, or as you say, some family member might be, you know, affected in some way by that, but nobody has any idea, you know, unless it's made obvious. So I think if there is, you know, an avenue to go down, make things as easy as possible for people to get that self-referral help if need be, then the better it will be overall, for everybody involved, really.
Yeah, and there are so many things changing in the NHS. So, for example, I was in a meeting recently for CPP, so Community Planning Partnership, where we have County Council, all the trusts, St Barnabas, Age UK, Primary Care, all the groups of people coming together. I think it's important to be part of the conversation because it will impact you. So I know some people might think, oh, I don't have time to do that, but I think of it in a different way, where if you don't have a say at the start, you don't have a say when it's finished. Or the say might be, it would have been impacting you already to a level you might not feel that you have a control over. Whereas if you start participating at the beginning, you have more control over what's happening. And so I think the involvement's really important. And within Lincolnshire, all the clinical directors meet with each other. So we have sort of like an alliance where CDs come together and talk about different things. So we have colleagues, chief execs, and a few other people that come and talk about, what's latest, what's in the background, how it would impact on PCNs, and a few other things. And again, these are the things that some people might think they are nice to know, but not need to know.
Yeah.
And I would challenge that. I would say this is something that you need to know now, because it will sooner or later have an impact on you.
Yeah, no, definitely. You made a lot of good points there. And I suppose in terms of kind of moving on to the kind of third point that we'd look to discuss, kind of engagement with patients. I suppose some of what you've said there kind of leads on quite nicely to that, in terms of kind of, I suppose, getting in touch with people, or at least kind of reaching out to patients, in the way that they as individuals might prefer, if that makes sense. Because I know we discussed about, obviously, different age groups will respond to different things in different ways. I know we discussed previously about, for some it might be social media, it might be emails and text messages that have the desired effect, whereas for others it might be more kind of newsletters and I suppose more traditional styles. So it'd be good to kind of get a more in-depth idea in terms of that engagement for patients, really.
Definitely. So I think I would ask for general practice partners or anyone who's interested in thinking about it to think about population health and data. Because this is something that you will eventually come up with. I find it fascinating. I love doing it. But when you look, so for example, if you're in a practice with high deprivation for a variety of reasons, whether that's socioeconomic or mental health or a few other reasons, then you need to understand how to target them differently. So we talked about previously about age group. So of course, in the past, there's always been paper copy, read up about it, I'll post it to you. But now our population is vastly different. People consume information so differently. So besides making sure that information gets through to them, also making sure that they're able to communicate with you in a different way. So we have a younger population. How can we target those? We have an older population. How can we target this? We've got probably a middle group where they're working. How can we capture those patients? Or maybe their family. So I think thinking about different mode of communication, we need to think about how we can be more inclusive, because besides age, there are also cultural, socioeconomic, and health needs. So we talked about social media, newsletters, but perhaps community events. How can we create events, or maybe speaking to the patient and find out what do you actually need, because you need to speak to the patient, get their feedback, and adapt it accordingly. So it can be, for example, this adult eating disorder. How can we inform patient about it? So I talked about social media, I talked about paper copy, but what other things, what other outreach area I can get into? So perhaps community events, health fair, workshop, local gatherings, any of the areas like this, especially if I'm thinking, oh, for example, if I need to increase the diagnostics of hypertension in my community, but the group of people I'm trying to get to are very hard to reach because they're working or because they don't really come to us unless they've got a problem. And with high blood pressure, you never know because it's silent. So what can we do? So previously we've done like a pop-up blood pressure clinic in the shopping centre. We're considering doing it in the children's centre, places of religion, other groups and other local areas where people are already going. It's not asking people to do additional trips. This is utilizing what's already in place and working with your other groups, so with your neighborhood team, with your social prescribers, and with those external party of people, and think, how can we rethink care for patient? And the easiest way to do it is when you are a partner, because you can have that conversation. You have the say, you have the influence to say, right, what can we do? So I think that's one of the reason why I took on partnership as well, is to see how we can communicate and also able to listen to patient and adapting services based on patient's preference and needs. Because when you do that, you start to cultivate more trust and rapport with your patients.
Definitely, yeah. And I suppose since you've started as a partner, have you noticed, and I know you've mentioned a few examples there in terms of what you've done, but have you noticed a positive response from the patients themselves? Have they, kind of either said anything in particular, or has the response in terms of the attendance to these sort of things, I suppose, been as positive as you were hoping in terms of making
So
those changes?
I'm trying to get feedback from patients and staff, because I know we talk about patients quite a lot, but for me, one of the most important thing is I can't do this alone, and I can only do it with the people that I'm working with. So the well-being of staff is my utmost priority, and I need their buy-in, I need their engagement for any of these to be even possible. So and I've been getting feedback to say, since you've started, you really make a lot of difference. I feel that we are being really listened to, and so I think that for me is something great to hear, even though that was my intention to start. But for different people to come to me and say, it's really made a difference since you've started. We feel that we've been listened to, and we feel like there's been change made, and if we've got any problems, we feel really supported. I think that's, especially when we see so many practices either closing or people are burning out, I think that's really important to focus on. And from that, to get more collaboration within the practice to reach out further to other PCN colleagues and then to patients and the population. So work in progress, but I would say in the direction that I was hoping for.
Brilliant. Yeah, I know, as you said just then, even though it was your intention for that to be the case, I think it's just reassuring to know that it is working. And like you say, there are practices, unfortunately, that are, kind of closing or, not being able to, unfortunately, offer I suppose that same sort of level of care and those extra, ideas that you've come up with to reach out to more people, and knowing that has been so well received is obviously just a very, I'm sure encouraging, factor from your perspective. And as I say, especially when you say other practices are maybe struggling and closing in the area, to have the knowledge that the patients really do appreciate what it is that you're introducing and offering for them. I'm sure it's very, very well received. I'm sure you're very happy with that, as you say, even though it is a work in progress still.
It's always very good to get feedback from people, even if you're hoping that was the aim, to hear it coming from them to say, we really feel that we've been listened to. It's an amazing feeling. I think two things I want to talk about very briefly. One, when you talk about, we previously talked about diversity, and one of my roles is I try to address, or I'm working very hard to address, some systemic inequalities. So working with other stakeholders and see how can we improve racial discrimination, how can we reduce the gaps between global majority colleagues in getting promotion or progression or even get recruited. So there is a lot of things in progress, and sometimes I get asked, why are you trying to do so many things? But I see that as things that are overlapping each other. So for example, when I see systemic inequalities and when I look at the data, it will be the same everywhere else. It might be that we might not have that much data on primary care, but we still have the same problem, and it's everywhere. So how can we, so any place that I encounter, any place that I learn, I can always bring it back to where I am, bring it back to the PCN, bring it back to the practice. And I think that's really important. I think, and the other one I just want to quickly share about my experience when I'm reaching out to other colleagues within the stakeholders is when you have those inverted commas contacts, because you're speaking to them about other different things, when you want to raise a concern about something that's happened or you think the service has not really stepped up for somebody, it's much easier for you to get that answer to say, oh, I know who you are, we'll deal with this quickly. I know they should do that for everybody, of course, but it's because I know who to contact, I know how to go about it, and I know how to copy in the right people to make sure this is their urgent priority, for example. So even though the point of me doing this is not to say, the practice is doing such a great job, at the end of the day is how can we step up better for the patient. So I think my aim is to make sure that staff is my priority, and by focusing on that, the staff want to do a great job, or anyone wants to when they start work. Only a very small majority don't want to. And so if I give them an environment and provide them with the tools to do that, that will demonstrate on the patient outcomes.
Yeah, no, absolutely. I think it goes, I can't remember who it was, but I think it was something along the lines of, if you look after your staff will look after the customers, obviously in this case the patient. So I think it's vital to, as you said, make sure your staff are feeling as though they're well respected, they're being listened to, they've got, as you say, the tools to do the job to the best of their ability, and that in turn will filter down into the, I suppose, experience that the patients have, and hopefully moving forward continue to receive that positive feedback that you've been getting already. So it sounds as though you've got everything very, very well organised and very well planned out, which is reassuring to hear.
I think it's something that I am aspiring to, and that's what I am working towards with the previous partnership, working on that already, but I'm bringing a different lens, different perspective, and I want to say it's not all glamorous like we all talked about here. It is day by day, it is brick by brick, and it takes time, it takes investment. So don't think, oh, I haven't really gone really far yet, because one of my traits is being quite impatient. So I have to keep reminding myself 6 months is a very early time to see a massive change, but there are change, and any change or any movement in the right direction is good. And then reevaluate. I've heard a quote that says we often overestimate what we do in the short time, but underestimate what we can do in a long time, because we're so impatient. So being able to step back and take that perspective of, okay, what is realistic now, and if I can't get there yet, what can I do about it?
No, definitely, and obviously it'd be great, keeping in touch moving forwards and seeing how things develop, and potentially hosting another podcast together again at some point to see how things are going. But it sounds as though everything's got off to, for the most part, a very positive start for you, and still plenty of room to keep developing and growing, which is always good. So thank you ever so much for running through all that. It's been really insightful, and hopefully all the listeners will feel the same. I mean, just before we end, where can our listeners kind of get in touch with you or find you on social media? I know you're very active on LinkedIn, but
Yes, I would say LinkedIn would be the best way to find me. Either instant message me. I get quite a lot, and I try to reply to everybody. I think ask the question. Don't be afraid to think, oh, I don't know whether I can. Please do, because the worst you can get is, I don't know. But if you don't, it's definitely nothing that you get in return. So please do reach out. And if you think, oh, this might help some of my colleagues too, share the podcast, show them where they can get to. If your colleague's really struggling with well-being and burnout, please do listen to the Imperfect Clinician podcast. But LinkedIn will be the best way to get in touch with me. If you've got any questions, please do reach out to me directly, or via Rohan. I'm sure he can direct it to me after as well.
Absolutely, and we'll once the podcast is posted on LinkedIn and our other the other areas where we post the podcasts, I'll let you know, and we can both share and promote it as much as possible. But well, say again, thank you very much for taking the time to run through all that, Yuen. It's been great, and hopefully see you again on a podcast in the future as well.
It's been my pleasure. Thank you very much.
Thank you so much for listening, and we hope you'll join us next time for another episode of the Illuminating Primary Care Podcast.